Thank you, Luigi. While I have nothing to disclose financially, I have to disclose that coming to the burn hip meeting 30 years ago impacted my practice significantly, so I thank Professor Ziemenrock for the invitation to this meeting. I'm going to talk about the challenges we face in a unique patient group. Unfortunately, we still have a lot of patients that have high hip dislocations in our country and also some areas in Europe. The challenges we face come in two groups: the patient challenges and the challenges of the surgeon. The patient's main challenge is that they have pain. The pain can be muscle related because the hips are dislocated and the muscles are carrying a lot of force. There may be bone pain because the femoral head is rubbing against the pelvis. And of course, there may be spine pain due to the increased lumbar load doses we see in these patients. And there's also something I call psychosocial pain. These patients are significantly disfigured and they are disabled. So there are a lot of things we probably don't realize going on in the patient's mind. These patients not only suffer hip arthritis, they have spine and knee arthritis as well. And because of their disability, they have many difficulties in participating in the societal activities we take for granted. So now let's look at the surgeon's challenges. The major challenge comes from the distortion of the anatomy. And I first would like to start with the femur. As you know, the femur is severely dysplastic. The dimensions of the bone are very small. And we can often see a distorted femoral canal. When we look at the acetabulum is also severely dysplastic. But the main problem is that the bone has never carried any weight throughout the lifetime, so the bone quality can be very poor, and also the dimensions are very small. So there are some positive aspects of this. It was discussed previously as well. We still have a posterior column, and the ossified labrum may provide some support for our cup, but we have to be careful on the anterior column. And I'll cut back to that. The capsule is elongated, thickened, and adhered to the pelvis, and the acetabulum may be filled with soft tissue, which will make the placement of the cup difficult for us. The muscles are contracted, the ligaments have changed, the spine is deformed, as I mentioned, and some of these patients may have had surgery in the hip in their childhood, so the scar and additional disfigurement of the bone may cause problems, and we have to keep the sciatic nerve in mind. Our goals may differ from the patient. That's one of the main challenges, because what we want to do is give this patient a stable, long-lasting hip with equal leg lengths while avoiding complications. However, we have to keep in mind that by performing a total hip replacement, we may not be able to address all of these. The leg length may still be a problem. I don't think we can correct the spine deformity and, of course, the knee problems associated with the deformity. And we have to keep in mind that these are relatively younger patients than our osteoarthritic patients, and we have to consider the survival of the implants, so we have to use the best implants available. Well, the patient's motivation is very important too, because our aims and the patient's wishes may not align. We have to understand why the patient wants to have surgery. Is it because of the pain? Is it because of the cosmetic appearance? Is the patient complaining of the social disadvantages it's feeling? Or maybe it be even sexual problems, because these patients have a problem in abducting their hips. So let's look at the surgical challenges during surgery. I do this procedure under a general anesthesia because I want to make a wake-up test at the end of the procedure. The first step in surgery is to perform an adductor, subcutaneous abductor tenotomy using a Levin blade while the patient is still in supine position. After that, I flip the patient into a lateral decubitus position, make an extended posterolateral approach, and once we get under the fascia, I release the gluteus maximus off the femur completely, and then make an interosseous membrane release as well to achieve maximum soft tissue release around the hip joint. After that, I cut the external rotators, protect them. A capsulotomy, of course, is performed, and the femoral head is resected. And using the capsule as a guide, the hourglass capsule as a guide, I go into the acetabulum and try to find the acetabulum through the capsule, which I think helps me do that. And once, after cleaning out the inside of the acetabulum, I perform a complete capsulectomy to provide additional soft tissue release around the hip joint. So this is what we end up seeing. On the right side of the slide is the patient's head. Here you see the ossified labrum, which can provide additional support to our cup. This is the posterior column, which we can rely on to ream into, and we should avoid reaming the anterior column to place a cup. And here's what it looks like when you place the cup in if you follow these guidelines. Next, I turn my attention to the femoral side. You have to keep in mind you need small-sized stems in these patients. After placing a trial prosthesis, I don't try to attempt to pull the femur down because we know that it is almost impossible. Even if you achieve that, previous work has shown us that you can't put more strain on the sciatic nerve more than 1 inch. So how can we reduce the hip after that? What I do is I measure the distance between the center of the femoral head and the center of the acetabular cup and subtract 1 inch, about 3 centimeters from this distance, and this gives me the amount of resection I have to perform. Once I know how much resection I have to make, I make an oblique osteotomy immediately below the porous coating of the stem and take that amount of bone off using an oblique osteotomy. Once this out of the way, I make a trowel reduction with the trowel in place and then reduce the hip. After that, I ask the anesthesiologist to wake up the patient. After we observe dorsiflexion of the foot, then we bring in the actual implant to the field. Using the implant, we reduce the osteotomy, reduce the hip, and then supplement the osteotomy fixation with a compression plate using unicortical screw fixation. And this is what it looks like. Here's the patient, and now post-op surgery. So we first published our initial results, and I presented this at the European Hip Society meeting in 2007. We had pretty good functional results in this group of patients and good survivorship. However, initially we had a lot of complications. Keep in mind, my institution is a teaching hospital, so we had to let some of the fellows do some of the cases. We did have some serious complications, but personally I haven't had any complications in the last 15 years. Recently I've moved to using cross-linked polyethylene ceramic heads, which allowed me to increase the head size, prevent dislocation, and I switched to, in some cases, conical stems for the femoral side. I wanted to bring you an updated study, but because of the earthquake, We weren't able to finish it, but I have some preliminary results for you. We now collected another group of patients from 2005 to 2019 with a mean follow-up of 14 years. In this group of patients, again, we had very high Harris-Hip scores, and the forgotten joint score was 95. The Harris-Hip score increased significantly, and we still had some complications, but it was much less than the previous study. So here you see a newer patient. First one hip, and then after that is healed about 6 months later, we did the other hip. The pointer is not responding as well. So when we discuss this with the patient, if the patient's a bilateral case, we say that this is going to be a 1-year treatment for you. And we also did some more work to see what happens to these patients. Unfortunately, it's not advancing. Okay, sorry. So we looked at especially in bilateral patients, we thought that performing hips on both sides would improve the spinal alignment. Unfortunately, it didn't change. The lumbar lordosis did not improve. We looked at different osteotomy configurations. We tested this in a lab with different osteotomy models previously described, and the one that we use, a 45-degree oblique osteotomy, provided the best initial fixation. And so I would like to conclude saying that performing a total hip replacement in a high DDH case is really a challenge because of the distortion of the anatomy and having to deal with a younger patient. Our goals and the patient's goal may not always align, but in the end, you can achieve a satisfactory result. However, I would strongly suggest that before you tackle one of these cases on your own, go and see it done in a person that has done a surgery like this before, because these are really challenging cases. Thank you for your attention.